Excellent. Hi, everybody. I'm Dr. Mark Surrey. I'm going to be joined by my uh, colleague and partner in practice, Dr. Carolyn Alexander, to chat with you a little bit about things to know about when you're trying to conceive. So, uh, I have been the medical director of Southern California Reproductive Center and have got medical training at George Washington University, at UCLA, at Hammersmith Hospital at the University of London, and Monash University in Melbourne, Australia, uh, with training in reproductive medicine and surgery, as well as assisted reproductive technologies. Dr. Alexander has had training at both Johns Hopkins University and the University of California, Los Angeles, and has had specific training in reproductive endocrinology and infertility at Johns Hopkins Hospital in Baltimore, Maryland. And Dr. Alexander has been with us as the medical supervisor and a colleague, partner in the practice of reproductive medicine for 10 years, and she's a fantastic physician, and she's going to be chatting with you a little later about some of the things that we'd like you to know about. So we wanted to let you know that our center here is a private center. We perform assisted reproductive technologies, including things you may have heard of, like in vitro fertilization and embryo testing for our private practice, as well as two of the local medical centers, UCLA and Cedars-Sinai. And we've had more than 25 years at this site, which has enabled us to produce thousands of pregnancies. Our locations are primarily in Beverly Hills, Pasadena, Santa Barbara. And one of the things that sets us apart from other places is the excellent laboratory services that we provide here. There is an embryologist, Dr. Miller, who is world-renowned, who heads up our embryology laboratory. We have different certified directors. We perform preservation of eggs and embryos for fertility by a process called vitrification. We do embryo evaluation at an advanced stage by something called an embryoscope, which is a time-lapse video analysis. What we have enables us to perform the most advanced evaluation of you and your fertility by looking at your embryos with IVF, if that's something that's appropriate for you. So what we want to do is understand what fertility is and how to help you with your journey. That's Dr. Danzer, who's one of our other partners, who has been one of our founding physicians. And that's me. And what we need to know is that fertility is sort of a shared journey. And, time does make a difference. This is no emergency, but what we do know is as human beings, our egg quality and sometimes sperm parameters can decline And that's particularly true for women at a certain age, and it has to do with a decrease in fertility that occurs throughout the 30s. So there's no specific age beyond which it's not possible. So we want to have you guys aware of what's going on. And just so you know, this is just a population statistic that shows that the longer that you try to conceive, the longer it usually takes. So, when you go to see a friend, a colleague, a doctor, and they tell you, well, just relax, take a vacation, take another year, and don't worry about it. That may be true, but statistics don't really show that to be true. We think that if you're considering trying to conceive, it would be good to have an evaluation. These bar graphs are statistics that exist with populations. And the one that goes down most rapidly on the left is that of monthly fertility based upon chronologic age. And you can see that it becomes much lower in the 30s than it was in the 20s and lower in the 40s. So there's no one age that dictates this is the time when you have to conceive. We know that every one of us is some variation on this general idea, but the general idea is borne out by population statistics. And one of the main reasons for that has to do with the percentage of genetically normal eggs that we produce as human beings. And we see that that declines very sharply and becomes much lower in the 40s than it was in the 30s. So there's a natural process that goes on within the human ovary. And if you look at the way an ovary looks at birth, you see a lot of eggs there. When you look at the way the ovary looks at age 50, there are a very small number of eggs there. So this isn't something that happens at one specific age. It begins to decrease at puberty and continues until what we call menopause. So there are a lot of impacts that accessory lifestyles can have that relate to this. Emotional impacts are significant. It's nice to decrease stress, and less stress is better for all of us. So when we look at an evaluation of your fertility, we need to look at the anatomy of the reproductive system. And when we look at female reproductive anatomy in the pelvis, it looks kind of like this. The uterus, which looks a little bit like a triangle, is where menstruations come from. It's where pregnancies go in natural fertility. The ovaries, which are separate, different organ system, are where the eggs come from. The fallopian tubes carry the eggs and the sperm to the uterus or not. And if they don't work, there are ways of getting around them. So when we look at how to evaluate you, an easy, quick way to do this is by looking at an image of the reproductive system, which is able to be performed quickly and easily in an office with an ultrasound. The ultrasound that we're looking at now shows an ovary that is not only normal, but it has a lot of follicles. follicles are the little dark circles that you see that can contain eggs. So we utilize ultrasound to be able to create a base for you as an individual from which we see what's happening with those follicles. Are you ovulating yourself? Are you responding to stimulants that we may want to give you to ovulate? This is further modified by a hormone level called AMH. That stands for anti-Mullerian hormone. There's a normal range for that that is controlled and driven by your chronologic age. So when you're younger, those numbers are usually higher and lower when you're older. So we utilize a combination of the imaging of your ovarian tissue and your AMH range to be able to get to know you a little bit as it relates to the ability of the ovaries to produce follicles and to create a pregnancy. So the ultrasound and the AMH are important things to do, and they're probably something that can be done quickly and easily in an office such as ours, where you have the ability to take ultrasound images and utilize hormone levels. This is another test. It's a type of an X-ray that looks at the fallopian tubes by injecting a dye through the cervix like a pap smear and looking at the images of where the dyes go. So we can see, for example, with this image, that there are bilaterally patent or open fallopian tubes where the dyes go through. This indicates that the tubes are open and could function normally. Guys need to be tested as well, and it's pretty accurate to test guys with a semen analysis. And we know that there's supposed to be a certain number of sperm that are supposed to move in a certain way, and they're supposed to be structured in a certain way. And when we see a semen analysis, we're able to get an idea of whether there's a problem there or not. And if there's a problem, there could be lots of different reasons for that problem. One of the things that we like to encourage is a good lifestyle from the perspective of avoiding toxins to sperm production. Men make new sperm about every 90 days throughout their lives. So whatever it is that you did a year ago may be different than what you're doing now. Certain toxins that we know can adversely affect sperm production are alcohol, tobacco, certain drugs, and certain hormones. For example, some guys take testosterone, which is a male hormone, which may be good for certain things, but it's actually not good for sperm production. So guys, if you're taking testosterone, better not to, and the effects of the testosterone can last for at least 90 days. So we would encourage you to not drink heavily, not smoke, and not take certain hormones. And you're part of our evaluation. So we like to see both members of the couple before we're able to evaluate you. I'm going to now introduce you to my partner, Dr. Carolyn Alexander, who is going to chat with you a little bit about different types of treatment options that may be available to you. But I would encourage you to have an evaluation done to see what may be appropriate for you. Dr. Alexander is an experienced, excellent clinician who has
Hi,
had
Dr. Surrey.
terrific training, and we work together in every step of patient's evaluation and treatment. We have other doctors here as well, but we want to have Dr. Alexander chat with you a little bit, and so uh, we'll look forward to having her do that now. Dr. Alexander?
Hi, everybody. Hope you're all having a good day. Thanks, Dr. Surrey. I always see that ovary picture and I think of all the patients you've helped too. It's an honor to talk about a topic that means a lot to both of us and everybody here at SCRC, all the staff. And next slide. So we're going to jump right in and just talk about what we should know and how to, chat with your doctor, your providers, and your care team. I think it's important to talk openly. At some consults will ask, have you ever had an injury to the testicles? Have you had any medications that could have an impact, like Dr. Surrey mentioned? Some of the androgel or testosterone that gives men muscles and strength can impact sperm development. And so it can create a system in which spermatogenesis goes down for a little while. And so it's important to think things through. We also want to clarify expectations, talk about what we can do with your age, your ovarian reserve levels, the sperm quality, and how to optimize success. We have Isabel, our financial counselor, as well as a team of financial insurance verification teams since California started a new mandate to offer fertility benefits for certain patients who have certain employers. I think it's opened up a whole paradigm for some people. It's important to understand the diagnostic tests that Dr. Surrey just explained, why we use certain medications. Some medications work super duper well in some patients, and sometimes if we are over exercising or underweight or have other health conditions such as a prolactin issue, some medications won't work for those situations. We'll talk a bit about IUI or insemination, in vitro fertilization, and the timeliness to decisions, and that we work together collaboratively to come to a discussion and decision. And we think through questions. Patients, even last night, just sent me an article about this brand new rejuvenation for the ovaries. So our embryology director, she's a dynamo. She's looking into it. We're trying to understand what can we do to help advance patients' care and optimize the situation. Next slide. So these are the different types of treatment options. I'll break it down. Assisted reproductive technology is everything we do to assist helping us get pregnant. So there's in vitro fertilization, the embryo transfer, blastocyst transfer, which is an embryo that's developed for 5 to 7 days in the dish, and it becomes around 100 cells or a blastocyst. Intracytoplasmic sperm injection will show an actual image of that getting done. Our embryology team uses a high power microscope. They immobilize the fast sperm that looks morphologically healthy, places it perpendicular to the polar body, and carefully places the embryo and the sperm in the egg so that we can watch it develop into an embryo over that window of time, around 7 days in the embryology facility. We also have a donor sperm program where we work really diligently to check your genetics as well as the donor sperm genetics to make sure none of the autosomal recessive genes can cross over, as well as family history and specifications that you desire. And we have a team that's fantastic. We have an egg donation program, whether we want to think about the pros and cons of frozen donor eggs or fresh donor eggs, and we can discuss statistics as well as optimization, semen and embryo cryopreservation as well, and assisted hatching. It's a way to help the embryo where the zona pellucida or the outer rim of the egg gets very rigid and firm. And as the embryo is developing, sometimes it may need a benefit of help to get hatched so that it can grow into a expanded or hatching blastocyst to develop into the best stage that we can get so it can implant. Other infertility treatments are deeper dives into polycystic ovary syndrome. There's different phenotypes of polycystic ovary syndrome, and we could talk about that. Infertility acupuncture, we have a team of people on the first floor that help. They're fantastic. I was needing a little help and they helped me. And so I think, I really am a big believer that lowering our cortisol can also help. Intrauterine insemination is an option with super ovulation where we help you ovulate and we place the sperm gently inside. And gestational surrogacy is an important step. In some patients, they're not allowed to carry a pregnancy due to advanced lupus, renal insufficiency. Sometimes if they've had a prior pregnancy complication, which can be very challenging and emotionally hard. As Dr. Surrey mentioned, it's a group effort to think things through and decide on how to get the healthy surrogate. Next slide. In the egg retrieval timeline, so you always have to get a checklist or a baseline ultrasound to count the follicles. The follicles, as Dr. Surrey showed, the little black circles each have a microscopic egg that's smaller than a grain of salt inside. And during the baseline ultrasound, we can evaluate the uterus as well on 3D to look for any uterine malformations or fibroids or polyps as well, and at least get a preliminary view. A deeper view is the tests that Dr. Surrey had mentioned earlier. The ovarian stimulation protocol can vary. There are many different protocols to recruit the follicles to grow. And so during the ovarian stimulation protocol, there are around 5 visits. We open at 6:30 in the morning, so if you have to hurry in and out to get to work on time, we accommodate a lot of patients that way. In addition, we get a blood test to make sure the estradiol is not going too high, which can be a red flag or risk for ovarian hyperstimulation syndrome. And during that visit, we make sure you're feeling well, that you have enough medications. We check on you, make sure everything's going smoothly. The 10 to 14 days of injections, most patients can feel breast tenderness, headache, mood swings, thirsty, some constipation. Some people feel great and want to do exercise, but we don't want vigorous exercise during the shots because the ovary, heaven forbid, can flip or turn, which is called ovarian torsion. And so we want to be a little cautious with that. So you have to do just walking. That's our best and safest way you can and have a good long walk, and we encourage that for circulation. There is an important procedure after around 36 hours after the trigger shot. It's called the egg retrieval. It's under anesthesia. We have an MD anesthesiologist who checks on you, watches you during the whole process, and keeps an eye through the process of the egg retrieval. And during that window, a thin needle is placed gently through the vagina and carefully under ultrasound guidance goes into the follicle and obtains the egg. And that egg is then cleaned off and can be fertilized with the embryology team, or it could be naturally inseminated with sperm. And that discussion is important to think through with your doctor as well. Then the embryology team watches the embryo grow for 7 days in the dish, and we freeze the embryos for future use. Next slide. The egg retrieval this is an image of the thin needle going in through the back wall of the vagina, carefully into the ovary. As you can see on the right-hand side, the ovary has little follicles, which is each little black circle, which is fluid that can be visualized on the ultrasound. And as the stimulation protocol develops, the follicles enlarge and get to a certain size. We try to predict how the follicles will have a mature egg by the size, your estrogen, how many days of stimulation, how you're feeling. We want to avoid ovarian hyperstimulation syndrome. We want to recognize if you're starting to have free fluid or ascites in the pelvis. So then we have to be cautious to encourage you to make sure to drink 2 liters of water a day and to avoid constipation so your system's a go. And this is the image of the needle, the white line coming through into the ovary and into the follicle. And next slide. And then the egg is cleared off. This is the cytoplasm of the egg, and this is the ICSI procedure getting performed. The sperm is this little circle being gently placed into the lemma, through the lemma, into the cytoplasm. Cytoplasm's aspirated into the pipette, and then the sperm is placed in perpendicular to the polar body. And that's ICSI being performed. As you can see on the right-hand side, there's a holding pipette, the oocyte, the sperm cell, and the ICSI pipette. Next slide. This is the embryoscope. It provides morphokinetic data. It can't change the destiny of the genetics of the egg or sperm or the embryo, but it involves watching the embryo develop, and it can provide information on the ability of the embryo as it developed to, if it had what's called abnormal divisions. If it went, instead of 2, 4, 8, 16, 32, sometimes it can go 2, 5, 10. And so, or it can have a 2, 3, and then back to 2 division. And so the embryoscope provides information. It is helpful in patients who have more than one genetically normal embryo. And the genetic testing tests for aneuploidy screening, as well as sometimes for genetic situations where we carry the same autosomal recessive gene as our partner, or potentially an autosomal dominant disorder as well, or X-linked disorder. Next slide. I love this image. This is an image on the right now. The team is preparing the embryo to take the biopsy to do pre-implantation genetic testing. The same cells can have the DNA amplified for aneuploidy screening, which is the chromosome screening, as well as then for the genes that you're concerned about. If you have a specific PGTM gene that you need to test, the same biopsy is used for both components of the tests. As you can see on the left, this is the fertilized egg at the 2-cell stage, the 4-cell stage, the 8-cell stage, 16 cells, and then it multiplies up to the blastocyst, which has approximately 100 cells. Next slide. When we're monitoring, we do blood tests and ultrasounds, and we check on you, make sure you have all the medications and all the feeling well. We give you some tips. And for the frozen embryo thawed days, it's thawed the morning of the embryo transfer. A lot of patients ask us about that. And so as soon as we find out the embryo survived the thaw, we're in it with you. We're very involved with all the steps. And the embryos is prepared and loaded into the transfer catheter as we make sure your has a full bladder and that you're ready for the embryo transfer after the protocol's done. The pregnancy test is around 10 to 14 days after the embryo transfer. And there's a lot more involved before a frozen embryo transfer, so I think we could add a bit to this information. But basically, we want to make sure you're on prenatal vitamins for folic acid to prevent spina bifida. That's important for a few months before your embryo transfer. You want to have your vitamin D level optimized with your doctor. You want to make sure you're as fit as possible. So if your body mass index is over 28, it can be important because each point over 28 impacts the statistics of the embryo transfer success. We want to make sure you're not iron deficient because pre-pregnancy iron deficiency has ramifications for preterm labor. We also want to make sure you're not using retinol. We try to avoid all the spray tanners and too many chemicals that could have components that may not be as ideal for the early embryo developing. And we want to make sure that you, if you have autoimmune issues, that you get a deeper dive with an immunologist. If you have any other health conditions, as we mentioned, some patients have pre-existing diabetes, lupus, rheumatoid arthritis, any health issues, you want to get a full checkup. If you're at the age that a mammograms do or have dense breasts, it's good to think about a bilateral breast ultrasound because we want to be like preparing for the Olympics when we're getting ready for a frozen embryo transfer. Your doctor will work closely with you to decide which type of protocol is the best to get the lining to be receptive for the embryo to attach. And we want to have a discussion if you're worried you might have endometriosis. Have a discussion with your doctor. There are newer tests and interesting MRI capabilities that can look very thin slices view to look for adenomyosis of the uterus, which can also impact the embryo transfer success. Next slide. So we're on this journey with you. I feel we all as a team feel the wins along the way. I always tell patients the morning of the egg retrieval, we're really focused on good egg quality, good sperm quality. And a lot of people are like, how many embryos will I get? Well, we focus on that, see how they fertilize, and we keep you updated each step of the way. You want to set healthy boundaries. A lot of people, even for myself, I'm an older parent, ask, are you going to have kids? When are you going to have kids? And those types of questions. And it's important to have tools to protect you from feeling overwhelmed or any anxiety feelings from that type of thing. You want to have a support system. I always say write your fears down and then tear them up because it kind of like breaks the cycle of worrying about certain things. Sometimes if patients tell me they're really, really worried about something, I notice it's not necessarily something we see typically in our day-to-day of doing egg retrievals, embryo transfers, taking care of patients. And so it may be important to open up if you have a specific concern or worry or question. We answer questions frequently through the portal system, and people really like that because it's me and Dr. Surrey and all the doctors answering the questions. So the team asks us the questions and we get the answers promptly there. So you want to feel comfortable with your team, and we're honored to be part of the journey. I think starting the new year, it does feel like this exciting thoughts of what can we do to help the next set of patients, and what can we, how can we optimize things in the lab, reading all these articles with our team and trying to keep everybody up to speed. So next slide. And so we have a winter freeze special. It's 25% off egg freeze, so feel free to speak to the teammates about that. Next slide. And we have a fantastic event about Path to Parenthood, Donor and Surrogacy Information Night. It's on February 19th from 5 to 7, and that would be fun to get to meet you. Next slide. our team is a wonderful pool of doctors where we all really work well together and take good care of each other. And so we'd be honored to take care of you. And we're happy to answer any questions as well. I think one question we always get is how long can the egg stay frozen? One of these images was from an egg frozen 14 years, which was a really one of the longest eggs we've had frozen, and it thawed well and became a healthy baby. In the past, we used to say to try to think about using the eggs by 10 years, but now we have data that they can last even longer. They're in a vitrified state, so they're frozen. And in general, around age 45, sometimes the microvasculature can start to change, but we're allowed to transfer embryos into the uterus into our 50s, as long as you're have an up-to-date annual physical exam, get a checkup with maternal fetal medicine, and have a discussion about it. And so make sure if you need a mammogram or breast ultrasound, make sure your pap smear's up to date. You want to be as fit as possible and optimize all the health parameters. And then let's think what else. Did anybody else have any questions? You can place them in the chat if you have any questions too. Thank you guys for your time and wish you all a healthy journey and best wishes. Take care.